I grew up in Yaoundé, like I said before, and Yaoundé is predominantly a French-speaking city because Cameroon is a bilingual country, and Cameroonians, you have about 40% of the country that's English-speaking and 60% that's French-speaking. And my parents are originally from the English-speaking part of the country. But because they chose to move to the city, Yaoundé, that's where they had jobs, I sort of grew up more exposed to French. And growing up in Yaoundé, I think by the time I was 4, I was speaking 3 languages because I was fluent in my mother tongue, Mungaka, and I was fluent in French and in English. The fact that both of my parents are academics kind of puts me and puts us in, we're more of like a middle class family. And that just means that you might have access to things that other people who are from a lower social tier might not be able to access. For instance, very early on, I mean, we had a computer at home, we had music lessons, we had exposure to things that maybe some of my classmates at school couldn't really access. So lots of exposure, and growing up in what is a typical African city, but at the same time having an outlook to the world. And my mom is she's a language teacher, and she majored in literature. And I remember when we were in the university and when we were growing up, she was very insistent on us reading, getting an interest in reading novels and getting interested in literature, but particularly reading African literature and knowing a little bit more about, writers from the continent. Because one of the dangers of westernization is that a lot of the literature that you have access to is Western literature, but there's fantastic African literature. When you see the Western perspective of the African story, it's only one side of the story. And it turns to focus on things that are usually the negatives. I always tell my friends from the West who've never been to Africa that, in Africa, people fall in love, people sing, people dance, we're dancing all the time, but this doesn't really come across when you watch the media reports. It's always about, Ebola and hunger and war. And, you kind of miss out on these other things. It's like just one single narrative of Africa. Whereas it's such a diverse continent and there's so much richness and so much good stuff. A lot of the African literature is written in English or in French because that is the reality of post-colonial Africa. Cameroon, for example, has over 200 languages, and I mean languages, not dialects. These are individual languages. And none of the Cameroonian authors or writers write in any of the local language. They write either in English or in French because it's the medium that is chosen as the official language. The 2 official languages in Cameroon are English and French. None of the local languages are, are national or an official language. Because, and I think again, it comes back to my mom because growing up, she said, my first language was my mother tongue. I went to school without knowing how to speak a word of English. And my mom said, kids learn fast. The moment they get to school, within a week, she'll be speaking English. And I wasn't only speaking English within a week, I was speaking French as well. But that just giving me that mother tongue, it's something that it's my identity. I dream in Mungaka. I think in Mungaka. What comes out is just the translation. I certainly think that there are things that will be articulated better if I wrote a story in Mungaka that I can't quite express in English or French. That's just the way it is. Because I think that it's tied with some more emotion and things that I can't quite explain that I don't have when speaking in English or in French, and I just think it's beautiful that I have that. And it's one of the things that we seem to be losing because a lot of the younger generation in Cameroon do not teach their children the local language, because there's the common misconception that if you teach your child the local language, they will not be able to learn English. I guess, myself and my siblings, we completely disproved that point because it's not affected my learning of English or French. And I don't feel that I've been placed at any disadvantage by speaking Mangaka and learning that as my first language. In primary school, I was a very good student, but I also really loved to play. And I didn't really want to spend too much time worrying about homework and stuff like that. So I did well. I was always in the top 10 in my class, but never right. I wasn't bothered by being first because I always felt that, having fun and playing was a lot more fun than being on my books all the time. But my focus kind of just really changed when I went into high school, into what we call secondary school in Cameroon. So when you finish your primary school, you get into secondary school. And I think I just got more competitive. And I started taking my studies a lot more seriously because I think, the boys in my class were really competitive, and that kind of just kicked me. I'm like, I think I need to get in the competition. And from that point onward, I stayed at the top of my class until I graduated high school. And after high school, I got into medical school, and I graduated top of my class as well. So there was that shift between me being younger and then at 10, by the time I got into secondary school, just really focusing and getting really competitive and wanting to be at the top of my class. I had a really big advantage. My dad is a scientist, and he has always really, really encouraged us as girls, his girls, to chase whatever we wanted to pursue. And I think it was so important that he didn't limit our goals and our objectives, particularly when I consider the environment that we grew up in. We're talking about a very patriarchal and chauvinistic society where people tend to believe that if you're just a little bit too smart, you might not get married and have kids because, if she's smart, she's not going to listen to her husband and stuff like that. But we never got that vibe from my dad. He never saw what the society thought about how we would end up in terms of being married and having babies as something that we should focus on. He always said, focus on what really engages you. Focus on what you love to do, and I will support you. And for me, that just meant that, once I figured out that I loved science and wanted to be in science, he was an inspiration. And he really encouraged me. When I was graduating high school, I hadn't made up my mind about what I wanted to become. And I had the grades to go absolutely into anything. Very early on, I kind of realized that, I had a lot more satisfaction when I felt that I was in a role where I was impacting the lives of people. And I knew that, moving forward and deciding on a career choice, I definitely wanted to be in a position where my work and my career would go beyond just doing a 9-to-5 job. I wanted to be able to actually impact people. I wanted to be able to see what I did change people's lives. And I think that sort of way of thinking helped me to sort of narrow down the paths that I was willing to pursue. And once I got into medical school, I think I really realized that, this is it. This is what I was meant to do. This is what I really feel engages me. This is what I want to pursue. Helping people is very general, but I think once I got into medicine, it became more focused. It became more focused to my environment. And I think it's because that's sort of around the time when I developed interest, particularly in infectious diseases. And why infectious diseases? To me, it was because a lot of them are treatable and preventable in these settings. And especially when I started my clinical years, I really struggled with dealing with the cases of malaria, and the cases of meningitis in children, and sometimes having to see parents take their children back home because they could not afford the antibiotics to treat them. And you discharged the child knowing that that child was going to die. That is a preventable death right there. And, the very first patient that I lost, who has stayed with me to this day, was a 3-year-old with severe malaria, brought into the hospital in Yaoundé, the capital, severely anemic, needing a blood transfusion, and the parents could not afford to buy the blood. And the kid died in my arms. I've never cried that much. I was in the 4th year of medical school. I cried so much I couldn't, and I remember the attending physician telling me, you're going to have to deal with this. And I would buy treatments from my own pocket. And the nurses would say, you can't keep doing this. There's 10 others who are going to come after this particular child. And immediately I knew that, I wanted to be in infectious diseases, be part of the change in that environment, help to finding the solutions, helping to get better access to these life-saving treatments that, how many children were dying like that, And there was no doubt. I knew that that's where I wanted to stay. People cope with it in different ways. Some people get really jaded and completely desensitized. And I wouldn't judge them because you have to make a decision on how you're going to cope with this. But you can choose to be that person who becomes a cynic and just says, yeah, well, another one bites the dust. I move on and I go home and I can process it and come to work the next day. Or you can choose to be that person who tries to do stuff that would cause a chain reaction and start changing the way things happen in that setting. And I think one of the reasons why I decided to orient my career towards research and combining research with clinical practice is because I feel that as a 9-to-5 physician, you're really limited. You're very limited. You're going to deal with that kid whose parents cannot pay, and then what? You're never going to influence policy. You're never going to find out the information that allows you to devise a new treatment or devise a new vaccine that can prevent some of this condition. So I wanted to be able to have a role that would have a far further wider reach, as opposed to, just being the emergency bit of plaster that stops a problem when there's a massive leak. You have to go and address the problem. You have to stop the leaks at some point. So that I find it more rewarding now to be in a role where I feel that I am beginning to contribute to the solutions. It will take time. I have absolutely I'm under no illusion that it's going to happen like that. But, with time, things will change. And it moves me from that frustrated perspective where I'm just sitting in the clinic watching children come in and die because their parents can't afford blood transfusions or because they didn't sleep under a mosquito net and they have malaria. All of these being treatable, preventable disease conditions. I can remember, and I remember very fondly, my first experience to research because it was a huge learning process to me. And also a very challenging process, but I guess it sort of reinforced my decision to sort of take that path. And it was in my final year of medical school, we had to carry out a research project. And that research project was part of a graded assessment for your medical degree. So I was looking for a mentor. I knew I wanted to work in HIV. So I approached a professor in my medical school who was doing work on HIV drug resistance. At that particular time, they had just started rolling out, or there was increasing access to antiretroviral treatment to prevent transmission of the virus from mother to child. But one of the things that you would find most commonly in a lot of African countries and in that setting is that a lot of the data that is used to create guidelines does not come from these places. Sometimes it's extrapolations of data from abroad. And there's a huge importance of carrying out research locally to then inform on what the policy should be. So at that time, we really wanted to look at what the prevalence of HIV drug resistance was in these women who had received the drugs to prevent transmission of the virus to their babies, because there was no local data available. And I wanted to make a comparison looking at what the prevalence was in rural settings with the urban settings, because obviously there are access issues depending on where you find yourself within the country. And, you know, I started by having to go through the ethical clearance process to get an authorization to carry out my study. So my mentor, you know, we sat down, we designed the study, we made sure that we had dotted the I's and crossed the T's in terms of the ethical issues. And to get the ethical clearance, I had to drop off, you know, my research proposal in an office in the Ministry of Health. And I paid, you know, $20 processing fee. 2 weeks later, I come back to the ministry and I pick up, you know, a signed ethical clearance form authorizing me to carry on with the study. No evaluation report whatsoever, no questions asked, and I was going to be collecting blood samples, clinical information from women in multiple sites within the country. First of all, I mean, that's mind-boggling. That's a study dealing directly with human subjects. And for $20, I just got a pass to do that. You know, so I asked my mentor, is that it? And he said, yeah, that actually pretty much is all you have to do. So I was the one on the field. I spent a period, it took me about 8 months to get these women recruited into my study. So I was doing the process of informed consent myself. And I had my informed consent form that I was going through with the patients and talking to them, explaining stuff to them and telling them I would bring back their results to the centers, because the drug resistance testing we're going to do normally costs about $250. So they would normally not be able to access that type of testing. But if you give back the clinical information to their doctors, then they can weed out the drugs they're resistant to and know what treatment to give them. And it just, I collected the samples and I got consent from some of the participants. Some of them refused to participate. We respected that. And then the samples were processed. I came to the US at the CDC, where we were working in collaboration with the CDC, and I processed the samples. I got trained to process the samples, and then returned to Cameroon, went back to the centers, and gave the results to their attending physicians. And some of them had their treatments modified based on that result. And it just really drove home how useful research can be, especially if you're able to take the information that you get and then feed it back into that system. But one of the other things that it highlighted, you know, when I was carrying out this study, in the rural centers, when I was visiting the rural centers in some of the sites, one of the things that I noticed was in some of the centers, the nurses in charge of giving the drugs to the women told me, we frequently run out of drugs. So sometimes we go through 6 months without any drugs to give to the women. And at the time, there were 2 drugs that they were giving to the women, and there was one drug that was meant to be given once during labor, and there was another drug that the women had to take for a month after delivery. So I asked, what happens when you run out of one? They said, we just substitute it with the other at the same dose. And these nurses had supposedly undergone training to learn how to prescribe these drugs. Here was I, completely scandalized, and I went to see the head of the unit, like the person in charge of treatment centers in that region of the country, and she just told me, this can't get to the ministry. You can't say this anywhere, because that will make me look bad. But I said, clearly there's something wrong. The message is not getting across. It drives drug resistance to get women, nurses substituting the wrong drugs. It increases the side effects because they're giving a completely different drug at the same dose as the drug that is not available, and it just completely messes up the whole system. You know, but I wrote a report and I gave it to this woman because I had to follow the channel of authority, but I don't know where it ever ended up. because no one ever said anything about it. So it again revealed some of the difficulties that you have when you're dealing with settings such as this. So my very first experience with research was a mixed bag. While I was able to give useful information to the patients and their physicians to help to improve on their treatments, some of the stuff I found out that could be improved probably got swept under the carpet because someone didn't want to look bad. I think that it would be really useful if researchers for a moment just took up their researcher hat and put on the hat of a study participant. Because if you ask yourself the question of, would I be a part of this trial if I was on the other side, and that answer is no, then that kind of begins to answer the question of whether you've gotten the right balance. So we're talking about the researchers, we're talking about the sponsors, we're talking about the people who participate in the research, and we're talking about the governments that are letting this research come in. It's engaging these stakeholders in the planning stages of the research. It's having those conversations in the planning stages. Oftentimes we're thinking about the issues of access only once we're finished. So now it's over, what are we going to do about getting this treatment out to people? But if you have these conversations before, these vulnerable communities, they're not stupid. I think if you explain things to them, you can negotiate with them and they know exactly what they're getting into, what you're bringing to the community, and what they're getting out of the research. And at the same time, engaging that conversation would get them to think a little bit more about the sacrifices that they're going to have to make in order to get access to this healthcare. But the conversations need to be had early on. I think the biggest hurdle is the local governments. And I think because there is a real disconnect between the government and the populations that they serve. So it's going to have to come through leadership, proper leadership, starting at the top, and then it will trickle down to the bottom. I think that right now, there's an imbalance between people that don't care and the people that care and want change. And I would think we need to move that balance, get people who care and who are passionate about changing the way things are done to outnumber those who don't want to see change. But again, that's going to take time. It's going to take time getting the information to people, raising awareness on these issues. Because I think one of the issues that really impedes on the process of getting local governments to really see this as a problem, again, is highlighting what happens. The official in the ministry who sits there and signs the consent form, he never goes on the ground to find out what's happening. But if this happened to a member of his family, then it becomes personal. I think people need to hear these stories more. The narrative is getting lost about what is actually happening in these trials. Like I bring you back to this official who wasn't even aware that in their own district, the nurses who had been trained to dispense antiretroviral treatment didn't know what they were doing. They were replacing drugs with the wrong thing, but that's the person who is supposed to be monitoring the system. So unless you get people to view it from the perspective of the person at the receiving end, only then can you begin to see change. The main thing about guiding the conversation would be getting the people from the West to think long and hard about the context. The context is very different from where they're coming from. And unless they understand the context, they would not understand the challenges of working and carrying out research and respecting ethical boundaries in that setting. There is insufficient financial resources and human resources. There is insufficient training of people and experience with reviewing the ethics of research. And there is a context permissive to corruption, where it's very easy to get an official in the ministry to overlook ethical issues within a research proposal, especially if they perceive that there's some benefit in it for them. So those are the three key issues. And I think that On the Western side of things, some of the research groups sometimes come in and just cut the corners and go with the flow. It's very important to decide that, okay, we're not bringing this into your country unless we've got this happening within a certain regulatory framework. If you cannot carry out that trial here in Boston, if it's not going to pass review in Boston as is, it should not be done in Cameroon. You have to uphold the same standard. If there's a certain standard that must be met here, you have to ensure that you're meeting that standard in that particular country. And because these countries need that research, because they will be forced to come to the negotiating table, and they will have to improve on the regulations in place. That's when organizations like Primar can come in and supporting with training. Because if you make that as a requirement, the country does want this investment. It is an investment. It might come with improvements in the local hospital. It might come with training of personnel. They will come to the table. But you have to bring it up. It's not convenient. It's more convenient to cut corners and get your study done and get away. I think the main guidance is ensuring that you would not proceed with a study in a developing country setting if that study could not be carried out in your own setting. That's the key. Only then will we be able to sort of get some headway in improving the way in which things are done. A lot of this population we're talking about do not know their basic rights. So, I mean, you're not going to get sued if you leave and never show up again. I'll take an example of one of the things, an experience that I had. While practicing as a physician back home, there was a pharmaceutical company that had drug reps come into a rural hospital and give out free treatment for epilepsy to the doctors using an alternative treatment that is not on the minimum drug list, the WHO minimum drug list. So there's a minimum drug list that all district hospitals should have. And the main drug that they have accessible to treat epilepsy is phenobarbital, which is really cheap. We're talking less than $1 for a month's treatment. So everyone can access it. They replaced it with a drug, depakine, that costs valproic acid, that cost about 400 times more. And for a 3-year period, they gave out the drug for free. And, they just met with the doctors in the hospital and they said, we're going to be can you switch all your patients with epilepsy on this drug? Both drugs work fine, but one is not accessible in that particular area and the other one is. This went on for 3 years and then they left. Supply stopped. What do you think happened to all the epileptics who had switched treatment? Relapses and loss of control of their symptoms because you now had to switch them back to phenobarbital. The fact that that was able to happen in the first place again tells you that that's, from the pharmaceutical end, someone cutting corners. They'll not be able to do that here. But they did that in that environment because they can. And no one's looking. So you have to hold yourself to the same standard that you will be required to follow here. You don't have to be in just eye servitude and only do things that are right when someone's over your shoulder looking. Talking about it and raising and highlighting the problem, highlighting the stories, and sensitizing the populations at the other end that they do have some rights, kind of gets people to start thinking twice about cutting corners. When the sponsors start losing money through lawsuits and class action suits, then they would start thinking twice about getting in there and doing stuff that, they would normally not do elsewhere. If I were carrying out a research study in that particular area, I would bring together the traditional leaders and say, look, we've got this new amazing treatment that could be really useful to your people, but we need to try it out on certain groups of people. And we're going to do this through a clinical trial. Now, this is what the clinical trial is going to involve. It's going to have this number of benefits, but there are also this risk that are associated with the trial. And the information that we collect will be able to use to inform on this or this disease, and that could help people in your wider community. However, if during this trial, once we finish, there is no access to the treatments, you should let your local authorities know. You should know that you have the right to get legal counsel, to demand that this treatment be brought to you. Because people do not seek legal counsel or do not, because they feel they can't. They don't know that they can. And once they know, then there's that aha moment. I can actually demand more. The perspective is usually you coming in and presenting that as, I'm being so charitable to giving you this treatment. I'm saving your life. It's a very one-sided conversation. But if you're honest and you say there are risks, there are benefits, and there are guarantees that must be in place before we proceed, and if we don't live up to this, then you can actually sue or you can actually make demands, then they know that they've got a right and they can actually request stuff. It's because they don't know this that it goes unnoticed. I'm a huge advocate for local investigator-driven research. Because again, unless you understand the dynamics of the situation you're dealing with, there's very little that you can do to really influence the way in which things are done in that local environment. And you find that 97, when I was researching, doing some research for this talk, 97% of the funding for HIV/AIDS research in Africa comes from Europe and the United States. Who do you think the primary investigators are? People from these parts of the world. Only 2% of the funding is coming from the governments of middle and low income countries. So there is a need to push more local investigator-driven research, because then you get people who understand the dynamics working in collaboration with the sponsors and the researchers who come from outside. The governments need to support local research a bit more. It's not normal that in my country, the majority of the funding for important disease conditions in that region is coming from elsewhere. What is the government doing? How much of the government funds are being put into healthcare research? And until the governments in developing countries make healthcare research a priority, there would be very little change on some of these issues. I'm just really excited about, all this knowledge that I have and coming back to being a clinician again and creating that liaison, connecting my research with my clinical practice. So that's what I'm excited about. Now, the how to do it, that's the part that I dread people asking me, because you never quite know if the next step that you choose to take is going to lead you to where you want to be. My PhD was very much at the molecular level. And the thing with basic research is that sometimes it takes a couple of years to translate to an actual clinical setting. However, what I was focusing on, cell-to-cell spread of HIV, is an alternative way that the virus has of infecting cells. So normally the virus would have a classical way of infecting cells where you have a cell that's infected, it produces the virus, it's carried in the blood until it finds another cell and infects it. When you have cell-to-cell spread, usually you have an infected cell lying right next to an uninfected cell. And this can happen in your lymph nodes where there are millions of cells packed next to each other. When you have this situation, HIV does a really cool thing in that it's able to use the cellular machinery to create a stable junction, allowing it to move directly from one cell to another without diffusing in the blood. And that's what we call cell-to-cell spread of HIV. Now, this particular mode of viral spread gives a lot of advantages to the virus. First of all, it's quick. Secondly, you can have many more virions, many more viral particles rushing in from one cell to another. Thirdly, it's in a protected environment where the antibodies cannot efficiently neutralize the virus. And it's thought to be, at least in part, one of the reasons why we keep on having, we're not fully able to completely eliminate the virus from the body, because the general belief is that some amount of residual cell-to-cell spread is happening in the lymph nodes where the drug penetration might not be as optimal as in the bloodstream. It's also thought that because it is resistant to neutralization by some antibodies, it would be one of the reasons why it's difficult to find a vaccine and mount an efficient response against HIV. And it's also thought to be one of the key issues that we need to unlock and find out to address if we're going to find a cure to eradicate the virus. So the next thing that I'm thinking about from a clinical perspective is we are able to study cell-to-cell spread in a laboratory by looking at cells in a petri dish or, under a microscope and infecting the cells in a lab setting. How do we then study cell-to-cell spread in vivo? It's not that easy, like, put a little camera in your lymph nodes and see how much of cell-to-cell spread is going on. And if we can't visualize this or measure this in our patients, how then do we actually target this mode of viral spread? So right now, I think the next phase for my line of research would be to think about new ways in which we can study cell-to-cell spread in vivo. Because I think if we understand what actually happens in real life patients, it's the first step towards finding ways to better target this mode of transmission. So that's how I think it can be moved from a basic science perspective to a more real life clinical setting. My patients and their stories and their experiences are just such an important component of the reason why I do what I do and the drive behind what I do. And that was what I missed most, because being in the lab can be really isolating. So it was really refreshing just going back to the clinic and talking to real life patients and, real life patients as opposed to just looking at cells in the lab. I think that it's very important that as researchers, we learn how to put ourselves in the shoes of the study participant. I think too often we get absorbed by how exciting the research is and, the data and getting that paper published. And I think we are in a privileged position. We are in a very privileged position to be able to do the kind of research that we do. But that privilege comes with a huge responsibility. And I think we should have a bit more respect for what we do. And that responsibility should make us just pause for a moment and put ourselves in the shoes of the people who accept to participate in our research. And I think if we do that, we'll think beyond that next Nature paper or that next Science paper and just think about, what would happen to X or Y once we've left and we've had our paper published and we've got that promotion. And that would just make it a lot more worthwhile if we know that we're leaving them better off than they were before.